Uh, we're going to look at an investigation that surrounds mastery versus standard proficiency targets for basic laparoscopic skills training, the effect on skill transfer and retention from McGill and Montreal.
So good afternoon, everybody, and thank you very much for the opportunity to present our lab's work. As I think, my disclosures, Covidian gives our lab an unrestricted educational grant, and also we were lucky enough to secure a research grant from SAGES for this project. So I think as everybody sitting in the education simulation session certainly knows, there's a lot of interest currently in the use of simulation for the acquisition of surgical skills. However, there's actually a surprising lack of evidence guiding educators on the establishment of proficiency goals on simulators. FLS certification is currently required in order to be eligible for certification by the American Board of Surgery. So one of the concepts that the FLS curriculum currently emphasizes is that of part-task training, where trainees are encouraged to gain proficiency in simple components before moving on to more complex tasks. Another concept emphasized in the FLS curriculum is that of overtraining, which you can see here by the number of repetitions required. In particular, overtraining with a PEG transfer task seems to be important, as the proficiency level required for that task by the FLS curriculum is just the mean performance of 2 expert scores, rather than mean and 2 standard deviation range allowed for all the other tasks. So we set out to answer 2 questions regarding part-task training and overtraining. We wanted to see if practicing a basic FLS simulator task would in fact facilitate the learning of a more complex skill. And in order to look at overtraining, we wanted to see what the effect of overtraining on PEG transfer to a mastery level, rather than just a standard passing level, would be on both PEG transfer retention and the learning of the intercorporeal suturing task. We picked the MISTIL simulator for our study, both because it's been thoroughly validated and because of its clinical relevance, as I mentioned, as the manual skills component of the FLS program. I won't go over the details of this simulators. I think everybody here knows it. So we conducted a randomized control study where simulator-naive McGill students were stratified by gender, and then they all underwent baseline testing on the PEG transfer and intercorporeal suturing tasks. They were then randomized to one of 3 groups. The control group had no PEG transfer practice. The standard training group trained on PEG transfer to the standard FLS passing score, and the overtraining group trained on PEG transfer to a mastery level. They were all then trained in intercorporeal suturing by an educator blinded to their PEG transfer training status. 1 month later, all students returned for retention testing on both tasks. Oh, sorry. In order to analyze learning curves, we performed nonlinear regression, and where we essentially defined 2 parameters of interest. One was the learning plateau, or the asymptote, which is the theoretical best performance a student can achieve with infinite practice, and the other was the learning rate, or the number of trials to reach 95% of the learning plateau. So essentially that estimates how quickly a student is learning a new skill. We had 77 participants complete our study with 28 controls, 26 standard trained, and 23 overtrained participants. They did not differ in either their demographics or their baseline scores. So this is our part-task training results, looking at the intercorporeal suturing scores by trial number for each group. The green line that you see is the FLS passing score for the task. The yellow line is the standard trained participants. The red line is the control, so those are people that have never practiced PEG transfer. They just started with intercorporeal suturing right away. And the overtraining group, who trained to the 48-second target that the FLS curriculum requires, are in blue. As you can see, their scores are essentially the same. When we actually did our analysis, however, and we looked at the intercorporeal suturing, in order to investigate the effect of part-task training with PEG transfer, we looked at our controls in red, who are people that never had PEG transfer, versus anybody that had had any sort of PEG transfer training in green. And there is a statistical significance in the scores with the PEG transfer trained participants doing better. When we looked at the other parameters, we also found a statistical difference in learning rate with participants that had PEG transfer training learning a little bit quicker, although there were no statistically significant difference in their initial intercorporeal suturing score, nor the number of trials required to pass intercorporeal suturing. That said, as you can see, the differences here are actually very small, so while they're statistically significant, they're probably not clinically significant. When we looked at overtraining, we analyzed the difference in the scores at the retention session for PEG transfer from when the students completed their PEG transfer practice. And while both the standard trained and the overtrained students had a drop in their performance, the relative change in that performance, the difference was the same amongst the groups. In terms of efficiency of overtraining, we found that the overtraining group, I don't know if I can point, the overtraining group essentially saved about 10 minutes in intercorporeal suture training when, compared to the control group. However, they required 40 minutes of PEG transfer training time compared to obviously no time in the control group. So that the time that they saved in intercorporeal suturing is significantly less than the extra time they'd had to invest in PEG transfer practice. This is echoed in the transfer efficiency ratio, which for both groups is 0.16. In order for an intervention to be efficient, you would need a transfer efficiency ratio of more than 1. So in conclusion, we found that part task training with the PEG transfer task alone did not lead to clinically significant improvements in the learning curve for intercorporeal suturing. Overtraining on the PEG transfer task also did not improve skill retention. So as simulator-based surgical skills training increases, skills curricula must be refined in order to optimize the benefit to learners. Further investigation of proficiency-based training is therefore needed to improve the teaching of technical skills, both in simulator and operating room environments. So I'd like to acknowledge everybody in the lab, of course, our study participants, and the McGill Surgeon Scientist Program for salary support. Thank you very much.